Introduce our speaker today, Sharon Curran. Sharon is the CEO of Lenape Valley Foundation, which is a nonprofit organization in Bucks County that provides mental, behavioral health, early intervention, and intellectual disability services to more than 12,000 people each year. A licensed clinical social worker, Sharon upholds the mission of the agency while overseeing its over 30 clinical programs and 400 employees. Sharon's experience within the mental health and human services industry spans nearly 30 years. Thank you, Sharon, for joining us today.
All right. Thank you, Jessica. So I'm relying on Jessica in the background here to keep me on track and to assist me with this new way of doing presentations. So I'll start out by saying that I think that we've all become a little bit more IT skilled in the last 6 months, 7 months than we ever thought we would be. And you know, we were supposed to be doing this conference 6 months ago, so I would have never dreamt that I'd be here doing it virtually. So I'm excited about that. I think that the virtual world is kind of opens a whole new platform for us in communicating, and it also allows more people to join into things than before. I will also start by saying that I attended a conference about a month ago online, and I know how hard it is to attend something virtually because you get tired of sitting in your chair and watching a screen, right? So I will probably, depending on how the timing is, going to take a little break in the middle here just to let everybody get up, get a cup of coffee, take a break for 5 minutes if you need it, and then come back. To me, an hour and a half is a long time to sit and listen to one person talk. So it's my intention to take a little break in there and shake it up. I really would appreciate questions during the presentation. And so, like Jessica mentioned, there's a chat. So if you can type in your question, don't feel like you have to wait till the end. And I'm asking Jessica to kind of stay on top of those for me and to interrupt me with questions as needed. I always think that some dialogue is better than none. So let's try to have some questions and some dialogue. The other thing is just for those of you who have attended presentations that I've done in the past, I love giving away prizes and presents. And so my intention when I was going to do this months ago was to give some things away. Today, I will say, though, I'm having a flash giveaway of African violets. Isn't it beautiful? So my living room during COVID, I thought it would be a great idea to learn to propagate African violets and aloe vera plants. And I'm giving them away. So anybody wants an African violet plant, I will have them available. You can stop into Lenape and pick them up, or I might even deliver it to you. So if you'd like a plant, the next slide will show you my email address. And I'm going to say, shoot me an email, and you too can be the proud owner of a aloe vera plant or an African violet from all of the ones that I have created during COVID. So that's been my coping mechanism. Excuse me. So anyway, what we're going to talk about today are the signs and symptoms of mental illness and intellectual disabilities. All of this in, with the kind of the umbrella of in the aging population. Special considerations for aging with this group, resources, and then obviously to have some discussion, question and answers. A little bit about my background. Jessica said that I'm getting close to 30 years in the field, which is alarming to me because I still think I'm 20. But my career, I've had a great opportunities in my career is the best that I can say, in that I've been able to work in residential, crisis. I was a case manager for many years in the community, worked in the emergency room, social work, inpatient social work. So I've really had a variety of positions in my past. And, all of those now I find really are to my advantage because I understand what it's like to be out in the community with consumers. Okay, and I also understand from a different perspective, kind of, what it's like to actually be out doing the work. It's not just that I sit in an office somewhere. And to be honest with you, after becoming the COO and the CEO of Lenape, the thing that I miss the most is being out in the community with clients. And so I have a hard time not jumping in and wanting to go out on a call with the crisis team and things like that. So I will say that I can hear someone talking, so I'm going to ask that you mute yourself, please.
I don't know what I want you to do because I don't know how to get in.
I don't either.
How did you get in?
So I'm asking, I can hear two people talking.
Here, but I just want to...
Sounds confusion about getting into the presentation, and if you could push the mute button, that would be very helpful.
Linda, can you please mute yourself? We can hear you.
All right, so let's start with, this is a, and I know that this group, historically, when I've presented at the Neff Symposium, is really a lot of professionals, and then some just people in the community who are interested, and other people in other fields that are interested in protecting individuals in the aging population, certainly from abuse, neglect, and I have pop-ups showing up on my screen. I'm sorry. Try to stop that. And so I do have a little bit of that in my presentation about, protecting a vulnerable population. But to get started, we're just going to talk a little bit about what is an intellectual disability and a mental illness and what is the difference. This is an area where many professionals even will sometimes kind of cross the two. And so the important things to think about around the differences, an intellectual disability is really in reference to IQ and impairment. And so I have to say that the person has to have an IQ below 70, and then they have to have an impairment in an area of adaptive behaviors. And what is an adaptive behavior? It's the stuff that we do every day in kind of caring for ourselves, like daily living skills. So getting dressed, cooking meals for ourselves, paying bills, that kind of thing. The other area where there would, they have to have a deficit in one of these areas. So another area that they could have a deficit in would be in communicating with other people, whether there are, also some perceptual issues with that communication. Another area that can have a deficit is social skills. So that area of deficit in one of these other areas of functioning can be a variety of things. And I have to say that someone can have a deficit in one area and then actually excel in another. So they could have, typical behaviors for instance, the one case that I can give as an example is my cousin who has some issues around intellectual disability. And I say issues because I've never been told exactly what the whole diagnosis is, but she has a job. She lives in her own apartment. But if you were to ask her to count change, the difference between a quarter and $100 bill is something that she doesn't understand. And no amount of teaching and, trying to work around that has helped her. She still, when it comes to money, finances, paying for things, buying things, she just doesn't understand that part of functioning. And so that's where I'm saying is that, she does have a job. It is in a sandwich shop and is able to do that, is able to talk with people and has really good interpersonal skills. But that other side of her brain, her functioning around money and all of that kind of thing is a very serious deficit. So let's move to mental illness is actually in kind of the category of things that we think of when we hear about depression, anxiety, and to be diagnosed, it has to impact thinking, emotions, behavior, and it has to have disruption in your life. So, and mental illness, like intellectual disabilities, are often on a scale of mild impairment to profound impairment, where someone struggles to maintain life independently and they actually have to be in some form of care. So the big difference here and why I have them side by side is that one has around an IQ, an intelligence level, and mental illness, people have normal IQ and can actually have a high IQ. So it's not uncommon for folks in those categories to have a kind of a, in some diagnoses to have an above average intelligence. So those are kind of some differences between an intellectual disability and a mental illness. More about that here. I put this little screen here so that you can actually see the speaker, but I see that it kind of interferes a little. So examples of intellectual disability would be somebody with Down syndrome. Again, I already mentioned the second bullet point. The other thing that's really important to talk about with an intellectual disability is that the age of the diagnosis is really important. And so a diagnosis can take place in school settings when there's testing done there, or by a behavioral health center if they do testing on someone to determine their IQ. And we'll get into this more as the presentation goes on, but to become eligible for benefits under that, the intellectual disabilities through the state or county, the person has to have that diagnosis before they're 21 years old. We have to be able to prove that. And you would think that most circumstances that people would be linked in their childhood to services, but that's not always accurate. And there are many families that take care of their loved ones and they're not linked to other services. They may have some service in the school, but they're not linked to a provider organization through the county, such as providers in this county like Pendel Mental Health, Lenape Valley Foundation, Penn Foundation. And when somebody is linked with an intellectual disability to services, that linkage and those services can span their entire life. That becomes very important late in life when maybe their typical caregivers can no longer care for them and they need somebody outside of the family unit to be caring for them. So early in life, the family might be doing that and able to do that, but late in life, they may not be able to. And that's why that linkage is really important. Mental illness, I mentioned the bullet points under this. And an interesting thing about mental illness per se is that the age of onset tends to be when people are younger, as in before 26 years old is most common. Now, within different diagnoses, there are different ages of onset. So anxiety disorders in particular are something that typically start in childhood. And so we don't think of that when we think about kids frequently. In fact, you'll think of a child who is having anxiety about their book report, or they have to stand up in front of the class, or anxiety about something at school. And sometimes I think that we don't appreciate that enough in the child. And we really need to, because often those anxiety disorders, if you're thinking, around 10, 11 years old, they begin and kind of build until what left untreated, unattended, unaddressed can develop into a full-blown anxiety disorder in their adult life. And so I think that a lot of early intervention for kids around anxiety in, starting in elementary and middle school is extraordinarily important, because if we can address it then, it might avoid lifelong struggles with that, or at least mitigate some of that struggle. There are other diagnoses, such as schizophrenia, that typically develop before somebody is 26 years old. To have it start after that age is atypical, and to have it late in life, you will, if you work with me, you'll hear me say that, at 80 years old, you typically do not develop schizophrenia. At 80 or in later life, a psychotic disorder is probably attributed to a medical condition, medication, an infection. And so even at 45 or 50, if somebody would come in with a first psychotic break, I would immediately start looking for something other than mental illness. I'd be looking at drug and alcohol use, and again, looking at infection or any kind of medication related interaction for that individual. So in mental illness, the onset is typically when people are younger for specific diagnoses, but then there are some that it can happen at any point in life, such as depression is one that at any age you can certainly develop a depressive episode. I know that that's a little bit confusing, but I think that when it comes down to working with people and being concerned, especially in the aging population, of an intellectual disability or a mental illness developing in an elderly person is a little less likely, in fact, not possible for some of those diagnoses. They have to develop earlier. And it's hard to kind of tease out what exactly is happening, because as someone ages, do we struggle more with some frontal lobe, higher reasoning things? And sometimes that does happen, and that's just a natural part of aging. And having been involved a lot with my parents as they aged and prior to them passing, I saw some of that capacity diminish. And it's not that they had an intellectual disability, right? That was just a typical part of aging. So, we're going to do a little talking about that, and I think that could certainly be questions that you might have for me in the presentation about what's typical aging and what actually is a diagnosis. Trying to move to the next slide. So the first thing I want to talk about is life expectancy. And this is an area that's upsetting to me working in this field, is that the general population, first of all, this is not upsetting, this is good, that the average life expectancy, depending on what statistics you go to, is around 80 years old. And certainly there's a difference between men and women. This is an estimate. However, if somebody has an intellectual disability, the life expectancy tends to be less. So you'll see here that 74, 68, 59 years old, and this is broken out by the severity of the disability. So for somebody who has a mild impairment, right now the average is around 74, but if they have a profound, severe diagnosis, it's as low as 59. Mental illness, the same thing, is that major mental illnesses, this range of 49 to 60 years old, life expectancy is the same as above in the ID, that it is based on the severity of the illness. So those people with a severe mental illness, the life expectancy is much shorter than for the people who have a mild impairment. So we're going to talk about why that is in a second here. So aging, though, in these populations are similar to the general population, but it often begins earlier, so they age faster, and it goes undetected. And so there are some specific medical areas where there are differences, such as certain cancers, diabetes, hypertension. When you think about mobility, there are a couple things here with an intellectual disability that we want to look at. And one is that there is research that shows that there's a higher rate of bone density loss in people with intellectual disabilities. Well, we all know that bone density in the general population, then you start talking about osteoporosis, thinning of the bones, and then can have some mobility things that follow that. So that is one of the things that could be occurring with someone with an intellectual disability, is bone density loss. The other thing is about coordination. And this is, the same happens in the general population. So for all of us, as we age, we become less flexible. Our balance will sometimes get a little bit wonky. And, I said earlier, or, I'm always saying I still think I'm 20 until it comes to coordination. And then every now and then I realize, geez, I'm not quite as limber and coordinated as I used to be. And same thing happens in an aging population with an intellectual disability, but the difference is it begins sooner. And they may not recognize it in the same way that you or I may have that insight into our personal aging in our body. And with osteoporosis, bone density, coordination, you have all the subsequent things that go with that. So if you're less agile and able to move, your ability to walk, to go out into the community, becomes problematic. And I sometimes think of situations that I've seen where people will say, Sally doesn't want to go on the trips anymore with everybody. She just won't go. She won't tell us why, but she's not interested. And in further exploring that with her, she may have developed a fear of falling, of tripping. And so it takes a little bit of detective work there with someone to figure out, why has there been this behavior change in the individual, and can it be attributed to common things such as pain, such as uncomfortable in their shoes. With my parents, again, shoes were a huge thing. I never thought I'd spend so much time trying to find the right pair of shoes for both of them. But with aging, it became uncomfortable, and there were certainly mobility things and then fears of tripping and falling. And so you want to look at that with someone with an intellectual disability and see if you can problem solve that with them. The other thing that I should mention here is that Down syndrome, there's a research going on in this arena where they see higher rates of Alzheimer's and dementia. And the suggestion for that is that we look at people who have Down syndrome a little earlier and try to do some screening, maybe in their 40s, maybe in their 50s, to get a baseline for Alzheimer's dementia so that we have something to compare to as they age. And I should say here as well that one of the things, when I was new in this field and when I was a kid, the belief was that people with Down syndrome and intellectual disabilities would not live as long as the rest of us. And they attributed it to some of these things such as heart disease. And I have to say that really what happened with that is a lack of medical care, not able to access the same things that other people would if they were to have those medical conditions. So today we see people with Down syndrome and intellectual disabilities retiring and living long, productive lives, which is just wonderful. But we need to do some things to help them to achieve that longer life. The other thing here with Down syndrome is aging is complicated sometimes by hyperthyroid and then depression. And I have to tell you that having spent most of my career working in mental health, there is a crossover with mental health and intellectual disabilities and also with drug and alcohol. There have been times where I've been at presentations where they'll say that individuals who have an intellectual disability cannot have a mental illness, that they can't have depression. In our work with suicide prevention, my agency, we were at a training with folks from across the country, and we asked, well, how do you screen for suicide risk in individuals with intellectual disabilities? And there was silence in the room, and it was crickets. And finally, broaching of the topic where there were some populations, groups such as coroners, who were saying that they would never deem a death of an individual with intellectual disability, they would never say that it was suicide because it just can't happen. And I think that is selling the individual with the intellectual disability short. I think that there is a risk of suicide. We have seen that in this population, and that we do need to screen and pay attention to that just like we would for any other group. It's just that we need to screen and ask the questions differently. So why is it different? Why is it that individuals with an intellectual disability have a reduced lifespan expectation? And it's all of these things. So again, it's like, if I were to go to my primary care doctor, the things that they tell me to do to age well are eat right, exercise, do things that are, intellectually stimulating to keep your brain going. And those are the areas where sometimes folks with an intellectual disability have not had those opportunities. There is a difference in the medical care that folks receive with an intellectual disability, and that is often they're not able to communicate everything to a doctor the same way that you or I would, or they're not asked the question, or sometimes it's overlooked. They'll say that something hurts or something is uncomfortable, and folks will attribute that to the disability and not that there could be a medical condition underlying it. The other thing that happens is diet and exercise may not be where it should be for folks. And so we want to encourage good eating habits and body movement, whatever that is. And we all know of, everyone has their likes and dislikes of what they want to eat and not eat. And it's really hard to have that conversation about eating vegetables is good for you if they just personally don't like vegetables, right? So again, more energy needs to go there. I put stigma on every slide. Almost I'd like to have like a little running ticker at the bottom here that says stigma, stigma, stigma. And that is, I think that sometimes the world in general makes a lot of assumptions and has a lot of beliefs about folks with disabilities that are just inaccurate. And the biggest thing that I've seen in my career is not listening to people and not being attuned to their needs. And then not listening to their family. You know, sometimes family members, a caregiver who's really involved with someone, will say that they know their loved one is just not right. There's something going on with them right now that is different, and they can't put their finger on it. We have to listen to that. And one of the first places that I would always go is into the world of physical health to see if there's something else happening with them. Long-term medication use. So in both mental illness and intellectual disabilities, the psychotropic medications do have implications in the long run, and some of those can cause physical health issues. Two biggest things that happen are hypertension and weight gain. And when we talk about weight gain with psychotropic medication, we're not talking about 5 pounds, we're talking about 50. And so when you have that type of weight gain, it has all kinds of consequences that goes with it. And sometimes the medication that causes the weight gain is the only one that's effective for the person. So then it's this give and take of, you know, can they be on a lower dose of it to reduce the side effect? And again, just, you know, could we get them on something different if that's what's causing some of the weight gain? I mentioned the history and the quality of healthcare. And in this population, I will say overall, the reason why the life expectancy is increasing and that the quality of life is improving for folks with disabilities is because the healthcare system in general, I think, is doing a better job. But we still have a ways to go there. We need to do better by all of these folks in regard to their health care, including mental health care as well as physical health care. So things to do, and this is again in the intellectual disability population. One is educating the individuals themselves about aging. So a funny thing is I was at my doctor when I was like in my late 40s and complaining about some ache or pain or something that was going on. And he said, Sharon, you know, at some point in life, you may have to just take some Aleve or Advil. That happens as you age. I was so offended. How could he be talking about me aging? You know, I'm still young. Well, you know, sometimes we have to educate that about the process. And in this situation, we'd have to be educating about aches and pains, and if they see other changes in themselves or feel something, to listen to them with that. And like I'm referencing taking Aleve or an Advil, that, you know, maybe they need that, and maybe that would improve their quality of life periodically if they're having some pain or, you know, just general aging related issues. The other thing I think about are activities. And I'm going to go back early in my career. I remember as a case manager, I had a client and who had a co-occurring, so an intellectual disability as well as a mental illness. And I was his case manager, and he was around 65, 70 years old in that area. And he had been going to a workshop most of his life and assembling things, which I would assume many of you are familiar with workshops. And we were in a meeting where he didn't want to go anymore. And I remember sitting in the meeting thinking, why can't he retire? Why is it at 70 we still expect him to go and do exactly what he's been doing his entire life? Now, the world has moved since then, and we do recognize now that people with an intellectual disability have the right to retire, right? You know, just like us, they may not want to be going to the workshop when they're 70, or it may be uncomfortable to sit in a chair and all of that. So, and assemble things. So part of this is we want people to be active, but then we also have to recognize that they will experience the same things that we do, such as less energy. They might want to watch soap operas during the day, some, or what about, you know, I remember asking my parents, can I take you to the art show that's going on? And that was the last thing they wanted to do because there were a bunch of people there and it was noisy. So to be conscious of crowds, noise, all of that can be just very aggravating, and that happens to most of us at some point. But we still want them to be active, so we have to find an alternative. And then assistive devices. What about a cane to walk with, or a walker, or a wheelchair, or not being able to hear? So how can you get the person to an audiologist to have their hearing tested and have the conversation with the provider about how to communicate with them, so that we could do a hearing test to determine, can they still hear? One of the things that we know that you become more and more withdrawn when you can't see what's going on around you and you can't hear it. And we need to be checking those things frequently for this population. Helpful tips. The one thing that I always think of whenever I hear of what is, I would say, put in quotes, bad behavior. So the person did something that is not typical for them, like they threw something in anger or they did something. Well, behavior is communication. The moment that starts happening, they're telling us something and they just can't put it into words or are struggling with it. So to look at any kind of behavior as communication with us. I've mentioned these others, looking for signs, maybe looking at some early detection of Alzheimer's dementia. I can't say enough about supporting the family, because it's extraordinarily hard to be the caregiver. And in an aging population, as they age, so does the family. And it gets harder and harder to do that. And again, another example of that is when I was caring for my parents, my siblings and we had a client at Lenape who the mom and dad were caring for their daughter, and she was my age and they were my parents' age. And I thought, how hard is this for this family, that the caregiver, it should be the reverse, right? It should be that the kids are trying to now help take care of mom and dad. And in fact, in this situation, the parents had to still be the primary caregiver for her. And, I was looking at my own mom and dad thinking there is just no way that they could help take care of me right now, physically or mentally. So again, a focus on caregiving there is extremely important for us and what we can do to help them. And overall, in everything here is being creative of, everybody's different, and we have to figure out what the thing is that this particular person needs, and that a cookie cutter approach does not work. And we have to, just be creative about the issues that they're having, as well as how we're going to intervene on them. More about caregivers. So I'm guessing that everyone on this presentation knows the history of institutionalization in our country. The fear of, you have a loved one that can't talk to you, tell you what's happening, the fear that they could be neglected or abused, that no one will take care of them as well as we will, as their family and their loved one. That is so powerful that is what keeps many families caring for their loved ones at home, is that there is a legitimate fear there. And so what can we do to overcome that? What can we do to find some security and safety for them if they need to be outside of the home? Or can we have people come in the home to help them out with it? The other thing is that I've seen repeatedly is that the family might rely on the person with the disability in different ways. So socially, it may be you have an elderly parent caring for a child who is now older, and it might be the parent's social contact with the world is that it may be all through their child. And so to have that child not in the home could be very difficult for them. It could be a significant loss for them. And for the individual with a disability as well, is that their link to the world is through mom or dad, and that the bond there is probably stronger or more complicated than a bond between a parent and a child without a disability. And for all reasons, it makes sense, right? The other thing is that sometimes the individual with a disability may have a check that they get, and the family might rely on some of that money. So when we start talking about aging in place versus in a nursing home or something like that, the family may be dependent on that the finances. This is also an area where we see exploitation. of family members or of a loved one is that somebody can be wanting that check but not be able to provide them the care that they need. And that's when we're, of course, bringing in Area Agency on Aging and making referrals and trying to figure out what's happening for that person. And I mentioned about the isolation. The other thing that is the unspoken reality of a family member with a disability is that not everyone around us understands that, and not everyone wants to understand it. I give the example, especially around drug and alcohol issues, but as well with mental illness and intellectual disabilities, is you have a neighbor who you find out is ill and they have cancer. And in our society, what are the things that we do for that family? The first thing we do is, can we bring a meal? Can we help with transportation? What could we do to be a support and a good friend? If the family member has a disability, an intellectual disability, a mental health disability, a drug and alcohol problem, and they're in a crisis, do we offer them the same support? I would hope that folks here today would offer the same support of making a meal, helping with transportation, that kind of thing. But our society doesn't always. And again, this is back to stigma that, we don't offer the same support for the family and the individual struggling that we do for other medical complications. So if anything, I would encourage everyone that if you know someone who's struggling, that you offer to make them dinner or something if you can help them out. And then lastly, but not by no means less important, is financial strain. So it can mean in a family who's maybe cared for somebody throughout the lifespan, that it may mean that one of the family members was not able to work that whole time. So they may have some financial burdens that other folks wouldn't have, or they could be paying privately for some things that may be able to be covered on benefits if it was done in a different way. And so there could be a lifelong financial strain on the family. And then there's also financial issues around planning for estate planning around the death of parents, and if they've been the ones supporting and taking care of their child, who's going, what will happen with their estate upon their death, which is a whole presentation in and of itself. I'm going to stop here briefly and check in with Jessica because I cannot see chat. And have there been any questions?
No. So far, we have not gotten any direct questions, but we encourage you to send them. If something has come up as Sharon's talking, please send us a chat. If anyone has any questions now, we'll take them.
And I would even go so far as to say that if you want to unmute yourself and just ask the question, you can, or feedback, as long as you remute after it. Questions, concerns, comments? Crickets? All right. I'm going to move then into talking about mental illness. And having another drink of coffee before I do that, which means more caffeine, and I'm more talkative. So if you have a question about this past, send it in now. All right, caffeinated, I'm taking off again here. So mental illness. So what are the differences with it? Higher rates of heart disease, diabetes, hypertension, and suicide. Any of you know me know that I spend a lot of time working in suicide prevention, and it is a disease in and of itself, I believe, and that just as deadly, if not more, than many physical illnesses, and higher rates of that certainly in the population with a underlying mental illness. There's also issues around infectious disease. And I was a case manager during the HIV crisis. And I have to say that many of my clients ended up positive during that time. And as well as hepatitis and tuberculosis. So why is that? And a variety of reasons as to why they're higher risk for infectious disease. A lot of it is around living situations. I worked with a lot of homeless folks in my early career, and tuberculosis there's a higher rate of that in individuals who have insecure housing or just no housing and are living in kind of group settings or on the street. Hepatitis and HIV, again, infectious diseases spread person to person. From sometimes this can be exposure due to their mental illness. And so to play that out for a moment is if you have somebody with a bipolar disorder who's maybe in a manic episode, there are symptoms of mania, such as hypersexuality, using substances, not taking precautions during all of that could lead them into high-risk behavior, whereas they could become exposed to HIV and hepatitis. So in our population, there's a higher incidence of those infectious diseases, and then in turn, a higher risk to those of us who work in this field for exposure to those diseases. So early in my career, I was exposed to tuberculosis. Previously didn't test positive. I now test positive for it. I know exactly when I was exposed and who it was, and lucky for me, didn't have symptoms. That is not uncommon for folks who do this in their careers. The other thing is a decrease in engagement with medical treatment. Here as well, I have had, and I'm not blaming the provider here. I'm just saying that mental illness is not seen as equal to a physical illness. So I have had physicians and other medical providers say to me directly, I have real sick people here and they're the priority, not the person who has the mental illness. And so with that goes undetected illnesses that in you or I would be diagnosed earlier. I've had young people die of things who have mental illness that should have never it should have never gone the way it did, and it was really because they weren't diagnosed properly and then they didn't have the adequate follow-up treatment. Another area that is of interest in working with an aging population is what is the role of depression? I could probably have a whole slideshow, a whole presentation on depression in the elderly. What I want to say about it is that we know for certain that when people are depressed, they heal slower, they take more medications than other folks do for physical health, as well as, and I'm jumping ahead here, I have a slide on this, they take more medication for physical health conditions. They are less, in the medical world, you would call it less compliant with treatment recommendations, meaning you are supposed to do physical therapy to help with balance, and they will go to one session and drop out, or maybe they never make it to one. And it's not that they don't want physical therapy, as they're so depressed that they're unable to organize themselves and take the initiative and actually get to the physical therapy session. So depression just has this far-reaching tentacles in the aging population that the repercussions of it are more than just around their mental health. It is about their housing, their physical health, their social interactions, really kind of every part of their life. And I think the most compelling for me is when you can see that people heal from infection slower when they're depressed. So that really talks about the mind-body connection. And I might be biased here, but it also says mental health conditions are equal to physical health, and it's absolutely a physical health condition, depression. And then in schizophrenia, we see some differences as well in folks' physical states, higher rate of diabetes, and then hypertension as a result of that, higher rates of heart failure, COPD, and hyperthyroidism. Reasons for that we'll get to here, but it's some of the same reasons that we talked about with intellectual disabilities, this slide should look familiar to you, but there's something different on this slide, and that is smoking. So, you know, we're a healthcare provider at Lenape Valley Foundation. I spent my whole career in healthcare. Do I encourage smoking? Absolutely not. But what is the percentage of the folks that we see with mental illness who smoke, and it's higher than the general population? There's a lot of debate about that. Why? And why, especially with a psychotic disorder, do people smoke? And there are studies that show that it actually calms people down. Sometimes it calms the symptoms down. And even if it does that, I still cannot say smoking's okay for this population. But the health consequences of the smoking have a serious impact of the overall pool of people when we look at life expectancy. Earlier, a couple slides back, I talked about the rate of homelessness. If you look at a homeless population, you see it in the news and the media, and they'll go in and they'll say 70% of the folks in this particular place have some kind of mental health condition or behavioral health, drug and alcohol, mental illness, intellectual disability. Just the being homeless in and of itself shortens the lifespan for all of the reasons that we've been talking about. And the homeless population in general certainly has a high rate of home housing issues. The other thing that we should throw in the mix here when we talk about illness and aging and mental illness is the population that's incarcerated. So folks who are incarcerated have a higher, back to that slide about communicable diseases, there's a higher rate of that, higher rate of depression, anxiety, and other diagnoses, and then not as good health care. So a lot of things kind of come in here. So things to do, stigma, of course. You'll walk away from here saying decrease stigma is a big thing. I could go on and on that anxiety and depression are not normal aging. And it is really hard to overcome the stigma with that, you know, if someone is older aging, why wouldn't they be depressed and anxious? Their friends have passed away. Their physical health is, you know, taken some hits, but that is not, folks do not have to be depressed and anxious as they age. And that we really need to talk about what can we do to help them? How can we get them into some kind of treatment or support that they are willing to engage in? And again, that might mean something creative. I go back to much of our world meets behavioral health needs through community resources, church, civic groups, loved ones, and visits from grandkids, you know, engagement in other things. Would that help the person's overall depression? Could we put something around them that would help them engage with the world that would decrease the anxiety and depression? And does it have to be a therapist? Maybe not. Maybe there'd be a different way. And so here's the thing, is to be really creative in that of how can we help folks with that if they're not willing to say, I have depression and anxiety, because we see a lot of that. And I'll talk about that at kind of towards the end, is that to acknowledge having depression or anxiety in certain age groups is more difficult than in others. And we still have that stigma, it's very prevalent in our elderly population right now. The other thing is to ask about symptoms, even if they don't tell us they have symptoms. So if you have a family that has arthritis and every other sibling and every other person, you might want to ask them if they're having any joint pain, because they just might not tell you about it. To explore any other health conditions that you think they might be susceptible to. I can't emphasize enough of finding a primary care doc that will work with you, and one that can have a conversation about, these are the ways to approach my loved one that work, and here are the ways that don't work. Again, I'm using my own family as an example here. I had the experience with my dad, 84 years old. So think about 84-year-old man who had been a superintendent of schools and veteran. And one of the doctors, when I was there, asked him in front of me if he was depressed. So what are the odds he's going to say yes in front of his daughter or even acknowledge depression? And the doctor then winked at me, really proud that he had asked if my dad was depressed. Here's the truth. He was depressed as all get out, but he would never, ever admit that. And he sure as heck wasn't going to say it in front of his daughter. So, some of this is, how do you approach this, and how do you get the doctor to work with them and address things in a way that the person's actually going to respond in a comfortable way with them. And, ways to, I did, because I tend to be assertive after that, say, he's never going to tell you in front of me. You should go have that conversation and ask about symptoms of depression without me in the room, which you get a whole different answer. So we may have to coach our healthcare providers. About the caregivers, when we're talking about mental illness, boy, the sun just changed and I am in this weird spot. So I'm going to move over a little. First of all, they might not have family, and not that they don't have family, it's that the family is no longer involved, or they may not be willing to be involved. And so goes back to stigma, but it can also be the history here. So one family that I know well in my personal life, who's the individual who has schizophrenia is about my age. And when he was younger, he became violent. He pushed his mom down the stairs once, injured her in another way at another point. And so when it came to who was going to care for him, look after him, it was a really difficult transition in the family. And some of it was because there was some fear. His sister was ended up being the primary caregiver for him later in life. And but there was this fear of him because during a psychotic episode when he was younger, he became violent. And so that is just a reality. And I'm not saying that to say all folks with a mental illness are dangerous, but the fact is that families may have been through episodes where things were out of control. And so now I've also seen families where it's the grandchildren that reach in and say, we can't have this go on because I don't want grandma to get hurt or grandpa to get, hurt or taken advantage of or something to happen to them. So when we're working with caregivers, we need to be conscious of that. And if they don't mention that, to ask, do you have fear towards your family member, and is it justified or is it not? They may be just worn out is the other part. When we get into individuals who had lifelong personality disorders, family members are sometimes tired. They will say it to us when we call trying to get help from them, as they will say, I've been down this road with him so many times, I'm not doing it again. I'm done. And so that really reduces the supports that they have in the world. And they may be then relying solely on paid professionals in the behavioral health system. The history that I mentioned previously about institutionalization, neglect, abuse, also then leads to behaviors because you're going to protect yourself in any way that you can. And that could lead to more stress, anxiety, and it can also lead to stress and anxiety for the family. If your loved one had something happen, it changes your view. And I can say it again from my own personal experience is, my stepdad had an injury, and I believe it was a result of some negligence on the part of an ambulance crew who slammed his finger in the door. And, I feel like you should be paying attention to that. I also know they were annoyed with him because he could be annoying at times. And so once you've had that happen, then after that, your reaction is just, I'm going to try to protect them in any way I can. And I'm not saying that it happens everywhere, but here or there, something happens. I've also worked in the field long enough to know that accidents happen. So I'm a realist about that, but we can't ignore the fear on both sides for the individual and for their family. I had previously mentioned relying on them for income and support. I had one family member tell me that, a dad said, she's my buddy. She's my little buddy. Wherever we go together, she puts the gas in the car and she pushes the grocery cart at the store for me. And losing his daughter was just so, I mean, that breaks your heart when you hear that. She's my buddy in life. And then lastly here, the rate of co-occurring with drug and alcohol is high, and statistics point to anywhere from 50% and above. Folks will have a co-occurring, either an active using or a history of it. So not that they're using now, but they may have recovered from the addiction. But that kind of plays in with the caregiver role here. And then again, stigma and bias about drug and alcohol use and seeing it as a disease and how we can manage that. I am going to take this is my promised break for everybody. So we are going to do a 5-minute stretch break. I actually was online prior to this trying to come up with music that I could play during this, but I'm not going to do that to all of you. So right now, my clock says 11:28. So at 11:35, we're going to be back here and finish the presentation for all of you. So if you have questions, comments, concerns, type them in. We're going to take a 5-minute hiatus here to get up, get a cup of coffee, run to the restroom, do whatever you need to do. And I will be back in 5 minutes. And I'm going to mute my video during this time. So, all right, ready to rock and roll here. So I tell you what, I'm aware of 2 comments in there. I'm going to do my last few slides, and then we're going to come back to that as a Q&A. Hopefully that'll work for everybody. So here's some just information about some other things to do in general. And I have to say that some of this is don't wait to sign people up for services and benefits. We see this in folks with intellectual disabilities, that sometimes the family is taking care of the person in every way possible, but it becomes a crisis when the caregivers get to a point where they can't do it any longer, or for younger people, when the individual is 21 and is now not going to be in high school any longer, and then they need help with their loved one. Again, on this, as I said earlier, the diagnosis has to be made prior to 21 years old for intellectual disability benefits. But you can sign them up later in life. So if you have proof of that back prior to 21 and they have deficits in areas of functioning and they meet the criteria, we can still get them signed up, and then it can help later in life. And one parent I spoke with said that, when his child was really young, he thought, I'm taking care of him. This is not an issue for us. And it really took people to convince him to get him signed up for some benefits, and now he sees why, because now he's at a place where he's not going to be able to continue to take care of him completely himself. And so that's the kind of thing that we need to be looking at all the time is, what's the game plan for down the road? So first one is don't wait until the service is needed, plan ahead. The next is about reaching out in the professional community and educating. And if you're a professional that works in our world, regardless of what your role is how can you educate yourself and others about serving this particular population? I'd mentioned before that going to the primary care physician, you need to find somebody that will have a conversation with you prior to an appointment and say, listen, I'm bringing in this individual that I work with, and they get very distracted easily. If you could do XYZ, that would help facilitate the appointment, or these are my concerns, or things like that. There are some folks who just get really distracted with, shiny things if it's on the ID side of the world, and that they could end up so fixated on like with me, a little thing on your neck, that then they don't answer questions, don't cooperate. And so if there are things like that you know about prior to, then tell the professional world what that is. And, as a caseworker, I used to have to do that with some of my clients there were a couple places I could take them where folks would listen to me and we could work something out. The dentist is a really difficult thing. And, dentists I could say, if you would do this and this and this, the odds of this appointment going better are, greatly enhanced. And I think that's with any of us. Again, this is generalizable to an aging population, is that if we know things that will make that appointment go better, then let's do it. But we need somebody to work with on the other side. And then the other thing is educating everybody around us, as well as the professionals, is just family, friends, and siblings. I think siblings are a special category because sometimes we leave them out of all of these discussions. So I earlier had mentioned that I have a cousin with an intellectual disability that I'm close with, and her sister, my aunt and uncle have never told her sister what the diagnosis is or where the deficits are exactly. So she has had testing. She's been involved in the system since birth. But her sister, who will be her caregiver once mom and dad are gone, they will not even discuss it with her, nor will they share any of that information with her. And so that really sets her up for a difficult transition if she just doesn't know. She knows what's obvious, but there may be other things there that would be helpful. So sometimes the siblings actually need more information, and also a discussion about, is this something that you're going to be able to do or that you want to do? And if not, then what is our other plan going to be? And in aging in general, I will say that as well, is, where is the person's siblings in their care or involvement in their case? And with my mom, her one sibling was her biggest supporter towards the end of her life. And yes, he's actually a few years older than her, but without him, it would have been that much harder for us. And he was just a tremendous support to all of us, and continues to be actually for me today. And so including him in planning and discussing, even though historically that was not his role, and they had independent lives just like most siblings do, but at the end, the two were really a pair, and to see them as a resource. And I've already gone over talking to the medical professionals before appointments, which I think is important if they will do that with you. And if they won't, then, maybe you need to find somebody else to work with. No, why are my slides? There we go. I had a moment of panic. So a resource that we have in Bucks County, oh, and look at this. Of course, now it's going to do it more than once. We have a resource in Bucks County that other counties don't have. And it really is a collaboration between the Bucks County Area Agency on Aging, Bucks County Mental Health and Intellectual Programs, or Developmental Programs, and Lenape Valley Foundation. And this program is called the SELF program. It serves people in our county who are more than 60 years old and have an unmet behavioral health need. And the criteria is that they have an unmet behavioral health need. They do not have a support network services helping them out. And the thing that is great about this program, I've been lucky that I was there when we started this and worked to get it going. It's really unique because we provide everything in their house, and there's no charge to the person for the service. So when somebody's referred to this program, first of all, I know the question is, how do I refer to this program? You call this phone number and they'll give you a referral form. And that form, you'll explain what is the behavioral health need. So you don't have to have a diagnosis. You don't have to know that, but you can say that this person just has, when I say behavioral health need, that is different than dementia and Alzheimer's. So we're talking about a diagnosable depression, anxiety, a psychotic disorder, drug and alcohol involved folks are also able to access this. You make the referral and say this person has a need. They're not currently being seen. They don't have supports and resources on their own. And we're asking if their case could be opened with this program. The referrals then reviewed by the Area Agency on Aging. They talk to Lenape to determine, is this a case that is appropriate for the SELF program? And then theoretically, let's say the person is opened with the program. the next step is whoever made this referral, we're probably reaching out and saying, will you help us make an introduction to the person? The person does not have to say, yes, I accept I have depression. So the one thing that we learned early on was that at one point in this program, we had most of the folks in it were in their 80s even, or late 70s and 80s. And one of the barriers to getting treatment was to say that, most of the folks wouldn't acknowledge that they had the illness. So as long as they'll acknowledge that something's going on and that they're willing to work with us, they're willing to let us into their house and cooperate with being evaluated by us, we can open their case. And then we work towards, an acknowledgement or recognition of kind of the struggles they're having. In the home, we provide case management. So that means help for resources for, kind of anything that they need, housing, finances, benefits, all that sort of thing. We provide therapy, so we have a therapist that will go out and meet with them, and we also can prescribe medications. So we have a nurse practitioner that works in the program that will go meet, evaluate, and then manage their psychiatric medicine. The program is really successful. Folks, our goal in this program is to treat them for whatever the presenting problem is, and then if they need ongoing support, that we will link them to a provider in the community near them. Individuals do stay open for a while with us, and so for a while, I'm saying can be months. We've had some that have gone over a year in how long it takes us to kind of work through everything that they need. It's allowed some people to stay in their homes longer when we've been able to get enough supports into the house to help them stay there. It's also, we've enabled some people to move into assisted living or nursing homes if that's the level of care they need. So we're very focused on getting them into the right level of service. The other thing that we've discovered is, we've had a number of reports to Area Agency on Aging because of abuse neglect. So when somebody's being taken care of, or taken advantage of, or there's some kind of fraud or something that was going on there that didn't work out, we worked heavily with Area Agency on Aging and law enforcement to report those situations. But several years ago, this program was recognized in the state of Pennsylvania as kind of an innovative program. We had the opportunity to go around the state and talk about it in different regions. And everyone was jealous and saying, how can we get this program in our county? So I feel like in Bucks, we have a luxury of having this here. And I would say that if you have referrals or questions, send them, call. The one thing that disqualifies, though, is if the person is in services right now, so they have a psychiatrist or they have something going on and it's just not working out really well, that disqualifies them from it. So this is the person who has no other services, behavioral health services right now. Available to them. So please refer and recognize that this is a resource. The other resources that I would point you to, Bucks County over the last several years has really just improved their website so much. And there's a list of providers in there who do services for people with intellectual disabilities as well as mental health. And I would say, go in there depending on what part of the county you're in and try to get somebody linked as close to their house as is possible. It's more successful. So we all are like that. If I have a doctor and I have to go into Philadelphia to go to that appointment, what are the odds of me doing that very often? Not really good, right? So, try to get them linked close to home. The other thing to keep in mind is that crisis services are available 24 hours a day, 7 days a week in Bucks County. So all you have to do to access crisis services is, again, go to Lenape's website and you'll see all of the resources in there. So now, last slide, the recipe for success is that everybody on this call today has a stake in this of collaborating and coordinating and communicating with each other. I find that, when I reach out to a group of people across the county in different areas of expertise, that when I just say, we need help with this case and this is what's going on, can I get some help? I get help, right? Folks will say, oh, have you thought about this? Have you thought about that? How can we partner? We really all have the same goal in mind, and that's helping the person. So by all means, reach out. Early in this presentation was my email address. And again, you can find me through Lenape's website or just call the agency if you're looking for me. I'm always interested in that collaboration across all of our programs. So now I'm going to stop sharing this PowerPoint. I do have a cool, oh, I meant to talk about COVID. Sorry, not last slide. The take-home message from this slide is really about isolation. I've done a lot of reading about this and also been witnessing it, during COVID, that isolation causes premature death, bottom line. And so we really need to be looking out for our seniors during this time because of the increased isolation. And the other thing I will say in our experience with COVID has been, what are the odds of our folks following the rules, meaning wear a mask, do this, do that? Not so good. For various reasons, they really struggle to do that. And so do some elderly folks, especially if you have breathing, COPD related things. And so it puts them at higher risk for COVID. And the other thing to take into consideration with all of this is right now you can access behavioral health, especially through telemedicine, but our senior and our aging population might struggle to do that just because of the technology, hearing and seeing. And so if that doesn't work, I would say that you need to reach out and kind of advocate for them. I know that all of the agencies that are public agencies, based service units, we have the ability to certainly see people in person if they need that, and will do that. And I think that most healthcare providers are doing that as well. But I do think that our senior population, aside from being at high risk just because of their age, I think they have all of these, things that layer on top that put them at higher risk. And I feel like sometimes we're not talking enough about isolation and the implications of that upon longevity. Now, I promise it's my last slide because I had these cool fireworks on it. So I'm going to stop sharing now and address a couple things in the chat. So I did see a thing here about home health, and you feel that folks are being diagnosed with depression and anxiety more often. And you can't equate age with depression. And I also think that any of us have, if you spend time with somebody who's older and you look on their life and you see all the things that they have experienced and gotten through on their life, you'll realize that they're pretty resilient. And I think that sometimes we sell people short who are older. My favorite example of this is my husband's grandma. His dad is always doing this thing of don't tell grandma because it'll upset her. And she is hilarious. She's turned 100 this month. And she has secretly said to my husband, she'll be sitting next to him on a sofa and she'll don't tell your dad, but I know all about that. And really, it's all good. And I said to him early on, I said, this lady has lived through so many things in 100 years. Do you really think that this is going to upset her? And the answer is, I think she's more resilient than we give her credit for. I have this pop-up thing that just keeps popping up and I keep clicking it off. Other things, do people know about the special needs trust that can be set up for folks? What I would say about that is important to mention that. And when people are doing estate planning, my advice is you really need to get legal advice on that and look at the special needs trust, because that can set things up so that it does not interfere with the person's benefits. And what you don't want is to leave them money so that then they're not eligible for benefits, and it gets really difficult. So if you're looking at estate planning, go to an attorney who specializes in special needs trusts. Is it possible to get services such as home aids for individuals without Medicaid? And I believe the answer would be yes, through the Medicare and through the Area Agency on Aging, but you should talk with Area Agency on Aging about that. I know that one of the things with Medicare, which I had experienced this in my life with my mom and dad, was that, if they can keep people in the community longer, they want to do that because just dollars and cents, it's less expensive than hospitals and nursing homes. I would say that, there are some things there, but there may be wait lists and limitations on what it is that the person is looking for. So it depends on, and then if it actually meets the needs that the person has, they'll offer some in-home health things. Is it frequent enough, et cetera? But there are things available in that. And, my experience with Area Agency on Aging is that they're just a wealth of knowledge, and that their caseworkers there, are just really great if you can get to talk to one of them. The other thing, will self take referrals of older adults who might be experiencing behavioral health issues due to a trauma? The answer is yes. And I would say as well with that is we might try to link them with NOVA and see if, we could do something together. So I think so. I mean, we'd have to go over the exact details of what's going on for the person, but my first blush at that is yes. We didn't even talk about how folks who are older experience trauma, deal with trauma, and kind of the shame and blame that comes out of that, and they're less likely to seek services for themselves. So anything that we could do to get them accessing services, we'd want to do. And again, we work a lot with NOVA because of their expertise in that area. So I would want to get in there and then link them and see what we can do. I work as an advocate for NOVA. There we go. You can always ask for her. Perfect. That is, and that's kind of what I'd be looking at. And if there are other ongoing behavioral health, to just let us know. And, I think self would be appropriate. So that brings me to the end. And I believe that I'm right on time because I think we're supposed to end at 11:55. I feel like I've just nonstop chatted. So it's a little different way to do a presentation. If any of you have needs, questions, things that you want to bring up, certainly do that. Shoot me an email is the quickest way to get a hold of me. Jessica just put in Lenape, our website, and my email. So send me an email. You can click on that. It'll get you there. I'm happy to answer your questions and link you wherever. I will tell you it's not an advertisement for Lenape Valley Foundation as much as I would like to do that. It really, I'll help get you to other service providers in the community as well as us. So I'm always happy to do that. So thank you all for being here. Thank you for hanging in. I'm impressed that we still have 67 people here, which is fabulous. And take care of yourselves. I know it's a really challenging time for all of us in general. So take care of yourselves. And I hope to see you in person at next year's symposium. So thanks so much.